Thank you for giving me the opportunity to share today's talk. I'm Professor Ian Wong. I'm a professor in pharmacy at the University of Hong Kong. Today's talk is carditis following COVID-19 vaccination. What have we learned from Hong Kong pharmacovigilance program?
So I need to acknowledge, I received a grant from the Hong Kong government to conduct the study, and also I have the colleagues from the Drug Office of the Department of Health and Health Hospital Authority for providing the data, and also my team from the CARE Program Research Team. I'm a member of Pharmacy and Poison Board of Hong Kong, which is the regulator in Hong Kong, a member of the Expert Committee on Clinical Event Assessment following COVID-19 immunization, and also a member of Advisory Panel on COVID-19 vaccine to the Hong Kong government.
Contents of today's talk. I give you the background and the introduction of COVID-19 vaccine response and evaluation care program in Hong Kong. And then I will use example of using different pharmacovigilance methods to monitor carditis following the BioNTech vaccination in children, including intensive monitoring study, active surveillance and background incident studies, and the record linkage electronic medical record study, and then finally a summary.
The prevention and control disease use of vaccine regulation allow the emergency use of COVID-19 vaccine in Hong Kong, and the pharmacovigilance program is needed to monitor the safety of the COVID-19 vaccine. And the CoronaVac from Sinovac Biotech in Hong Kong is used in Hong Kong, and also we have the BioNTech Comirnaty from Fosun BioNTech, equivalent to the Pfizer BioNTech in Hong Kong. So the CARE program is a part of enhanced pharmacovigilance plan of the Department of Health and led by the University of Hong Kong by myself. It's a 3-year research program, start with the COVID-19 vaccine program in February 2021. So CARE stands for the COVID-19 Vaccine Adverse Events Response and Evaluation Program. So we monitor about 40 different conditions endorsed by the WHO Global Advisory Committee on Vaccine Safety, and the list being used by the European Medicine Agents for the ISoP program. So the CARE program have different parts. The part 1 is looking into the background rate of the adverse event of special interest for monitoring the COVID-19 vaccine, and then active surveillance of the AESI, and also to evaluate the safety of the COVID-19 vaccine using electronic health record linkage study. And then we have the intensive monitoring study on the COVID-19 vaccine subject.
So we're going to use examples of using different pharmacovigilance methods to monitor carditis from the BioNTech vaccination. The first study I'm going to show you is the intensive monitoring study, is what we call the Part 4 study.
So this is the Part 4 study of the CARE program.
So the BioNTech vaccine have been available to adults since the February 2021, and it was offered to children aged 12 and above in Hong Kong starting on 10th of June 2021.
So we do prospective cohort design, and participants receive the BioNTech vaccine at community vaccine center, and we use the self-report adverse reaction data. So we collect the data from the baseline and then first, second, third, 7, and 14 days of the both doses. We use the generalized linear mixed model on vaccine adverse reactions. So we're looking into the pain, swelling, redness, itchiness, and also a systemic tiredness, fever, chills, muscle pain, nausea, rash, and also looking into severe like hypotension, dizziness, and wheezing. We recruited over 2,500 participants, and the top 5 most frequent observed adverse reaction across different age group: 12 to 17 years old, adolescent, 18 to 59 adults, and 60 and above elderly. And we can see that it's very similar pattern. Local pain, tiredness, muscle pain, headache, fever. They are the major frequent adverse drug reactions after the vaccination. These are the severe adverse reactions observed among children and adolescents. Mainly a dizziness. However, we were very surprised that we identified one case of carditis out of 1,000 participants. So that actually raised alarm bell at that particular point, and it prompted us to do further investigation. We conducted regression modeling, and then to calculate the adjusted odds ratio, we compared the young and the older people versus the middle-aged adult group between the 18 to 59 years old. So you can see in here, in general, the adverse drug reaction rate in the adolescent group is higher than the middle-aged group. And on the other hand, the older age group, the 60 and above, are actually lower than the middle age group. It's almost like a linear relationship. The younger you are, the more likely you suffer any local or systemic side effect. The older you are, the less likely you're going to suffer those things. So it actually quite fit into the hypothesis of for the younger children, they have a stronger immune response, hence they are more likely to suffer the adverse drug reaction. And vice versa, for the older people, maybe their immune response is less strong, so they suffer less side effect. And I think a lot of people observe this type of situation already. So the implication that we see here, the adolescents have moderate higher risk of local and systemic adverse reaction than adults after the vaccine inoculation. The adolescent adverse drug reaction tend to last longer in our study, and the sample size is sufficient to detect rare adverse reaction. So we need other part of the care program to do surveillance. But really unexpectedly, we detected one case of carditis, over almost only 1,000 children. So it is really alarming to us at that particular point.
The results were published in International Journal of Infectious Disease.
So the next example I am going to look into is using the active surveillance and the background incident to investigate the extent of carditis following the BioNTech vaccination in children. Well, we're looking into the background incident rate of carditis before the COVID-19 program had been implemented. So we're looking back into the last 10 years before the vaccination to give us an understanding of the background incident rate of carditis. And also, we're looking into the active surveillance of all the carditis following the vaccination. So we combine the two sets of data together, allow us to understand the extent of the carditis following BioNTech vaccination in children.
So carditis is a very rare and mostly self-limiting adverse drug reaction. Now in real life, not to do with the vaccine, the incidence rate of myocarditis is about 20 per 100,000, but a highlight is person year. It means that each year, not for just 14 days after vaccination. The case report of carditis following the use of the BioNTech are rapidly accumulating worldwide, and a significant proportion of this report describe younger male individual after receiving the second dose. And recent Israelite study demonstrated nearly about 3.24 relative risk in almost a million individuals.
For the benefit of our overseas participants, I'm going to give you some introduction about the Hong Kong healthcare system, and specifically our publicly funded healthcare system. It is highly efficient. It's been always ranked as top 1 or 2 in the world. Important characteristic of Hong Kong healthcare system, and specifically for the public funded healthcare system. In terms of the efficacy, we have about 95% of the people using our public healthcare system are Chinese. And we have universal coverage of public health system and heavily subsidized. So it means that the taxpayer pay majority of the cost of the publicly funded healthcare system. Now, most of the chronic illnesses and serious illnesses are treated by public health system. We also have a private healthcare system. It's a very large number of private primary care physicians in Hong Kong or general practitioners in Hong Kong, but they tend to look after minor ailments. And we also have private hospital look after people with insurance and more well-off citizens. But majority of people do use the publicly funded healthcare system. Hong Kong Hospital Authority is the sole public-funded acute healthcare provider of Hong Kong. The Hospital Authority is serving a population of over 7 million people through 42 hospitals, 47 specialist outpatient clinics, and 73 general outpatient clinics. It is heavily subsidized, so that's why it's highly popular, specifically for chronic illness. Hong Kong Hospital Authority HA has developed a comprehensive electronic medical record system. Single unique electronic medical record for each resident in Hong Kong. The unified system links up data from all 42 HA hospitals, 47 specialist outpatient clinics, and 73 general outpatient clinics. All data are stored in one single system. It aims for clinical management. However, we transfer data to clinical data analysis and reporting system. We call it CDAS, database for audit and research. So it means that no matter where is the patient seen, as long as the patient in a hospital authority, clinics or hospital, then we will be able to see the same record and also recording all the treatment and drugs and operation and diagnosis in a single record. The Clinical Data Analysis Reporting System database contains diagnosis, procedures, drug prescribing, drug dispensing history, admission and discharge details. It also contains laboratory and pathology results. It has a very unique mother and baby link. It means that we can actually evaluate maternal drug use, how it affects the baby in long term. And also currently it contains about 11 million people data.
Data collection. Vaccination data were collected from June 14 to September 4 from the Department of Health in Hong Kong of all adolescents aged 12 to 17 years old. The cases of myocarditis, pericarditis were identified using the Advanced Incident Reporting System, what we call AIR system, from the Hospital Authority of Hong Kong. Cases were then confirmed using the definition of the CEPI and also the Brighton Working Group definition. Myocarditis, pericarditis were identified as associated with vaccination if events were within the 14 days of either the first or second dose. Because looking into the information from the publication and also from ourselves, most of the cases are within 14 days of vaccination. Data collection, background rate comparison. We specifically look into 2020 as one of the comparison, and also looking into the average yearly rate between the 2011 and 2020. So the background rate of myocarditis and pericarditis were collected from the June 14 to September 4 from CDAS, our anonymized electronic medical record system of all adolescents aged between 12 and 17. The incidents were calculated per person per 14 days to make a fair comparison with the vaccination incident. The denominator of the incident was using the Census and Statistics Department for population of 12 to 17 years old in Hong Kong. Over 178,000 adolescents vaccinated with BioNTech vaccine in Hong Kong. We detected 33 cases of acute myocarditis, pericarditis following vaccination. So the overall reporting rate of acute myocarditis was about 18.52 per 100,000 vaccine recipients. So the first dose is 3.37, but the second dose is 21.22 per 100,000 vaccine recipient. So we can see that the second dose is actually 6 times higher in the adolescent compared to the first dose. And we're also looking into compare the data with the 2020 in Hong Kong. If we're looking into the incidence rate of the 14 days after vaccination, in the male population, we can see that it's about 5.57 per 100,000 people after the vaccination, and compared to the second dose in male is about 37.32. You can see again it's really high in the second dose, but also interestingly, looking into the females, we can see that the female is much lower than the male, whether it's a first dose or second dose. Now, if you look into the background incidence rate, that's very fascinating. The background incidence rate of the carditis in children are actually extremely low. We're talking about is less than 0.11 per 100,000 people if you follow them up for 14 days. And again, in male, it's higher than the female in the background incidence rate. So when we look into the incidence rate difference, we can see a huge difference between the vaccinated people and the unvaccinated people, or the background incident. So when we use the average data from the 2011 to 2020, and we can see that, and again, it's a huge difference between the vaccinated people and the background incident rate. And again, the male is far higher than the female. Having said that, we can still see that the female is higher after the vaccination than the background incident. So the reporting rate is much higher than the background incident rate after adjusted for gender and follow-up time. Now, carditis is still a very rare event for the last 10 years, in Hong Kong at least. Now, we have some limitation of our study. The background incident rate is based on the hospital authority data, so it is likely to be underestimated. And also, we know that there's detection bias because the patients and also the medical profession are much more vigilant looking into what actually happened after the vaccination. They may be actually more likely to report the carditis. Discussion. The overall incidence of acute carditis in male adolescent in Hong Kong was 18.52 per 100,000 people vaccinated. So the first dose is 5.57 and the second dose is 37.32. So you can see that there's a huge difference between the second dose and the first dose. If we would like to actually reduce the carditis caused by the vaccination, so clearly there's something need to be done on the second dose.
The results were published in the Clinical Infectious Disease. Hong Kong had very low infection rate during the study period, relatively less direct benefit to the adolescent have 2 doses of BioNTech. And the risk and benefit ratio will shift towards risk minimization, and Joint Scientific Committee recommended single dose or at least 12 weeks apart instead of 21 days apart.
So the interesting thing is, when we're looking into the data provided by the US CDC, they detected 6.7 reported cases in male aged between 12 to 17 years old. So you can see the difference between the two data sets. We detected 37.32. However, in the US, it's actually 6.7. So our reporting rate is 5 times higher. Now, at this particular point, we cannot really understand why there are such a big difference. It may be to do with our pharmacovigilance system is so effective. We use the active surveillance, we use electronic medical record to identify cases. So we are much more effective in identifying cases. However, we cannot exclude the possibility of the Chinese population in Hong Kong are at higher risk of carditis compared to the counterparts in our Caucasian population. Now I want to talk about the effect of the policy change. The cumulative incidence of carditis declined from 43 cases in over 200,000 vaccinated adolescents. It's about 21 cases per 100,000 adolescents to 0 cases out of 22,000 adolescents. So we can see that the implementation of single-dose policy is highly effective and indeed statistically highly significant. And so simply using the pharmacovigilance allows us to actually detect the risk of carditis so that we can implement policy change to reduce the adverse drug reaction in children.
However, subsequent fifth wave has changed the risk and benefit ratio. So it means that the first 2 doses of BioNTech vaccine were shortened from 12 weeks to 8 weeks in March, so that it can give quicker cover to the adolescent to the fifth wave, specifically on the Omicron. The study was published in JAMA Pediatrics 2 months ago.
So after I showed you the 2 different studies using 2 different designs, now I showed you the third study that we use the record linkage of electronic medical record to allow us to estimate the relative risk or the odds ratios of the carditis following the BioNTech vaccination. Just want to show you the overall scheme of the research. So this is the Part 3 study that we use the electronic medical record. So previously we talked about the background incident rate, active surveillance, and also intensive monitoring. And now we go to the more sophisticated analytical study. Well, we use the case control design. So basically we compare the people who have the carditis and with the people without the carditis and look back into the history about the vaccination exposure record and to calculate the odds ratio. We use the electronic medical record identified between the 23rd of February to 2nd of August, about 433 people have the diagnosis of carditis. And we excluded 69 people because they already had a carditis previously. And so we identified 364 are the new carditis cases. And then we exclude the people that they're under 12 years old because we don't have, they're not supposed to have vaccine at that particular point, and also have a subsequent diagnosis of myocarditis, myocardial infarction, and do not have the troponin level so that we can't confirm the cases, or have the troponin level within the normal range. And we also excluded people that we couldn't actually to match to the control, and luckily that we don't have anyone that we can't link up with the vaccination record. So they give us the cases. It's 160 carditis cases, and this is the control. So basically, the control are the people without the carditis. So originally it was 400,000 patients, and then we exclude some of the patients have the missing sex and date of birth and had a history of carditis. Again, it's not the new cases. And then we have the control in here. After we do the matching, we identified 1,533 patients as control. So here is the result. I think the most interesting result is after we adjusted all the odds ratio that we can see in here, the comparison between the coronavac, which is the inactivated virus platform, compared to the mRNA platform, the BioNTech one. You can see the difference immediately. So we couldn't see any significant increase in the odds ratio of the coronavac, but we saw that this is a 3.57, so it's a 3 times higher, which is quite similar to the Israelite study. But what is important is for us that the coronavac become a natural control group that you can gaze into the association. And again, when we do the stratified before with the male have a higher risk than the female side of it. And you can see that this is the female, this is the male. So clearly the male have a much higher risk of BioNTech compared to the female one. And indeed, the female one didn't actually reach a significant level at that particular point. You're looking into the older adult, about 80 years old, then in that case, it's 2.41. But when you're looking into the children between 12 to 17, the risk is certainly much higher. Although it didn't reach a statistical significant level compared between these two, it can tell you that the actual number is much higher. So the paper was published in the Annals of Internal Medicine earlier this year. We know most of the published studies, just like the one that we did, is looking into the risk of carditis following the priming doses, i.e. the first and the second dose of the BioNTech. Of course, we know that the WHO recommend to administer the booster dose, and indeed the fourth dose is coming already. So this increasing number of the case report also talk about the carditis following the third dose. So for us, the care program, we need to investigate this one so that we can inform our citizen in Hong Kong the risk of carditis following the booster dose. This is the crude incidence rate. Looking into, there are two different vaccines we have, is CoronaVac and the BioNTech. So first to go to have a look the CoronaVac. The CoronaVac is inactivated virus platform. We don't see any increased risk in here. They're all very close to 1, so it means that there's no higher than the control. But when we see the BioNTech one, clearly that it increased the risk in the first dose and much higher in the second dose. And then in the third dose, we don't see it higher than the second dose. So it is a good news for our citizens to know that the booster dose is no higher than the second dose. Now, this particular analysis, we're using the cell control case series, so it's an analytical study, and we're specifically looking into the analysis of carditis with elevated troponin. So it gives us some validation of those cases of real carditis. If you're looking into here, we can see that for this particular one, for the first dose of the BioNTech, you can tell that the risk increase specifically in the 1 to 14 days, and it's still raised about 15 to 28 days. But of course, overall, the 1 to 28 days still increased. And then similarly, for the second dose, we can see that the number is actually, the magnitude is much higher for the first 14 days. And again, it's increased overall of 1 to 28 days. Then for the third dose, again, you can see the similar pattern. The pattern is increase the risk of carditis of 1 to 14 days. But then you can see that the risk is also increased, but not statistically significant. I think it's because the number is smaller. But having said that, you're looking into the overall picture, we do actually think that the third dose is no higher risk than the second dose. But when we're looking into the CoronaVac, the inactivated platform, we just didn't see any increased risk at all. So the overall conclusion of the carditis side of it, we know that the increased risk of carditis, both myocarditis and pericarditis, after all 3 doses of BioNTech, but not CoronaVac. And the crude incidence rates are still very low, and the magnitude of the risk after the booster third dose was not higher than the second dose. And we know this one already, the male are more likely to have the carditis compared to the female, and certain the younger age group is also at a higher risk. If you did attend last year lecture, I presented the Bell palsy following the vaccination of the BioNTech and also the CoronaVac. It was published in the Lancet Infectious Disease. And also, we also published a paper in the Nature Communication looking into multi-morbidity and adverse events of special interest. Like in Hong Kong, we have a lot of vaccine hesitancy due to a lot of people think that if they have the multi-morbidity, they have much higher risk of adverse events following the vaccination. So there was some resistance in having the vaccination in this particular group. And that's why we conducted the study. We demonstrate there are no higher risk of having the adverse event than the people without the multi-morbidity. And as I demonstrated earlier on, that we use the data to conduct the study in looking into the myocarditis, looking into the risk factor, looking into the age, looking into the relative risk and odd ratios. And then we also use the electronic medical record to evaluate the policy of changing the vaccination recommendation. So I think today I demonstrate how we use of different pharmacovigilance methods, from intensive monitoring, surveillance, active surveillance, background incident, and using the full record linkage electronic medical record data to do the pharmacovigilance. So I think this is the model that we learn from using the data in Hong Kong, allow us to do a whole range of study to identify risk factor, change policy, and evaluation policy. So I hope they give you the idea the future analysis in different places could use the same method. Thank you for listening to my talk, and I hope you enjoy my talk. Feel free to visit our website. This is the website that we have, the Hong Kong Care Program, and or send me email to talk to me about some of my research, and we're more than happy to collaborate with other researcher and also other regulator. Thank you very much.